Good evening to everyone. I'm Dr. Onkar Swami on behalf of MQ Pharmaceuticals Limited. Welcome you all in this HIV update. In this HIV update, we always discussed very interesting presentations and followed by a lot of discussion. So today we will be having two presentations by two eminent faculty across the country discussing two very important clinically relevant topics. After these sessions, we will be having a panel discussion or a questions and answers session as well. So it gives me an immense pleasure to welcome our first speaker for the day, Dr. Swati Gohel. She will be speaking on challenging cases and uncommon presentation of common diseases. So Dr. Swati is an infectious disease specialist at SARTI, the Center for Infectious Disease at Ahmedabad. She is also consultant of infectious disease at Narayana Health Multi-Speciality Hospital, Ahmedabad. She is an alumnus of a BJ Medical College, Ahmedabad, and completed her fellowship from National Board of Infectious Disease from Apollo Hospital, Chennai. She has also completed her observership at Division of Infectious Disease at Wayne State University, Detroit, Michigan. She was a formal consultant of an infectious disease clinic at Vedanta, the Institute of Medical Science at Ahmedabad. She has numerous publications on her credit. So we welcome Dr. Swati for these sessions, and we look forward for your interesting presentation. At the same time, I take a privilege to introduce and welcome Dr. Vinay Devaraju. Dr. Vinay is an infectious disease physician with expertise in the handling simple and complicated infections, both in immunocompetent as well as immunocompromised patients at Apollo Hospital, Bangalore, India. He is an alumnus of a prestigious PGI Chandigarh and completed his internal medicine from this institute, and he is a fellow of National Board Infectious Disease from Institute of Infectious Disease, Apollo Hospital, Chennai. He has a special interest of pyrexia of unknown origin, tuberculosis, obstetrics and gynecological infections, orthopedic infections, transplant-related infections, and critical care infections. So he would be presenting today emergencies in HIV. So I will not take much of this time, and I would like to stop at this moment over here and hand over this session to our first speaker, Dr. Swati, to take the deliberation forward. Thank you very much. So we will be having questions and answers. So I request all the participants, please type your questions and put into the chat box. We will be taking these questions after two lectures. So over to Dr. Swati.
Thank you, Dr. Onkar, for a kind introduction. I hope my screen is visible and I am audible well.
Yes.
Thank you. At the outset, I would like to thank MCure organizing team for providing the platform. I will be discussing uncommon presentation of common diseases. So the first case, I would like to, name it as Christmas cake, because we encountered this case first in the first initial days of December 2022, and we tried to solve the case by the end of December, nearer to the Christmas. So here I have a 72-year-old male who is a retired farmer from Anand, which is a well-developed village in Gujarat. Patient was brought by distant relatives, caretaker, because patient's own kids are settled abroad. So we didn't have any nearby relatives to take proper history. Patient initially presented to the nephrology unit with bilateral lower limb swelling, which was going on since 2 months. He had gained weight roughly of 12 kgs in past 2 months, and he mentioned occasional episodes of hematuria. There was no any history of fever, cough, chest pain, or orthopnea, although he was giving history of breathlessness on exertion, NYHA class 2-3. There wasn't any burning micturition, decrease in output, etc. His past medical history was significant for diabetes mellitus type 2, which was there since 30 years, for which he was on OHA till this presentation. He had developed diabetic retinopathy as well as neuropathy. He was hypertensive since last 6 years. He was having morbid obesity with BMI of roughly 39 and query obstructive sleep apnea. In 2017, he was diagnosed with IHT, required primary PTCA in 2017. At that point in time, he was diagnosed as HIV positive, evaluated at the government sector, and started on TDF 3TC DTG based regimen. We couldn't get much details from 2017 as we did not have any near relatives, but one of the documented baseline CD4 counts were more than 250, and supposedly he was asymptomatic at that point of time, apart from his chronic underlying medical issues. His wife was reportedly negative at that point of time. On examination, there was pallor. He had bilateral pedal edema up to the knee. I will be describing mostly the positive findings. He was hemodynamically stable with blood pressure slightly on a lower side. On systemic examination, there were bilateral basal crepes on auscultation. Rest of the examination was fine. There wasn't any peripheral lymphadenopathy rash or any oral or genital ulcers at the time of presentation. These were some of the investigation. I have marked red the abnormal investigation. So he was having anemia, hemoglobin of 9.6, 10.2. Total counts were normal, platelets were fine, liver function tests were fine. He was having borderline low albumin, but not to very severe hypoalbuminemia. He had creatinine of 1.48. Here, I would like to mention that his baseline creatinine that was 3 months before this presentation was 1.01, which was normal based on according to his weight and age. His creatinine was 1.48 and it was rapidly rising, not to very high level, but it was rapidly rising. So it went up to 1.8 when he came to us. Rest of the electrolytes were normal. I would like to spend 2 minutes on his urine analysis. I have taken a screenshot of his urine routine. I think you are able to see my cursor. You can notice here, there was a heavy proteinuria that was +3 of protein. He was diabetic, not controlled sugar. So sugar was +2, few WBCs. He was having hematuria. The RBCs were 100. He had some granular cast. And here, very important finding, he had 10% dysmorphic RBCs on urine examinations. His C3 levels were low. Chest X-ray was normal except the bilateral minimal pleural effusion, and CRP was on a higher side. The rest of the infective workup was negative for hepatitis B, hepatitis C. His create ratio was negated, and his 24-hour urinary protein was 7 gram per deciliter, which a nephrotic range of proteinuria. You can skip this at this point of time. So diagnosis from the nephrology unit was nephrotic syndrome. This was his ultrasound kidney. Because of hematuria, we wanted to rule out any stones, but there was no stones, only mild increase in echogenicity of cortex with CM differentiation maintained. Bilateral pleural effusion, there was nothing much actually on the USG abdomen. So straightforward, they went ahead and did a biopsy, which is ideally indicated in such kind of cases. And they came to the diagnosis of histopathological diagnosis of membranous nephropathy. Here, I want you to take 1 minute more. If you can see on IHC, the immunofluorescence staining, apart from the IgA and IgM, rest all markers are positive, which is not very common what we see in membranous nephropathy. So he was positive for IgG, C3, C1q, kappa, lambda, and PLA2R staining was negative. So what does this suggest? PLA2R staining is for the idiopathic membranous nephropathy. So it is there to differentiate whether this is secondary to something or this is idiopathic. This is being negative stems that this is a secondary membranous nephropathy, secondary to something. Let it be autoimmune, let it be infective, let it be any other. This is not idiopathic, right? This is when patient was referred for the ID consultation with two main questions. Question was, we need to change the ART because patient's creatinine is rising and patient is on tenofovir. So very simple question. I think we can take care of this. Another question was a bit tricky, which said that they asked for the clearance of immunosuppression because they wanted to give rituximab, which is the treatment of choice for membranous nephropathy. Right, after ruling out common secondary causes, which they had ruled out, it seems. So what is the ID diagnosis at this point of time? So we have a HIV positive patient whom we need to stage by checking viral load and immunological status. checking CD4 count and load. And he has membranous nephropathy related kidney involvement. So we need to probably safely switch to a non-nephrotoxic ART. And obviously we need to rule out any other give clearance for the immunosuppressant because we do not know what is his baseline HIV status. So we asked the chest and we asked for a HIV workup. His CD4 count, his baseline CD4 count was more than 250. Here the CD4 count was 456, 28%, which was quite good. His HIV viral load was not detected. This was confirmed HIV-1 infection. The viral load was not detected. So we were quite happy about it. Now it becomes easy. Patient is virologically, immunologically well controlled. So probably we just have to deal with the AKI. But that was not that easy. He was positive for HLA-B 5701. So now there is a risk of abacavir hypersensitivity if we start this patient on abacavir, which makes this case a bit more complicated. So how do we proceed in this case? So these were the questions. What is the cause for membranous nephropathy? We know that this is secondary. Although from the nephrology side, ruled out all possible causes of secondary nephropathy, we have to see whether they are missing anything or not. Second thing, what ART to be considered in view of AKI? Because we cannot use abacavir in this case. Can we use zidovudine? That will be really tricky in such cases. His hemoglobin is already 9. And clearance for immunosuppression. We said no for till we do further workup in this case. We are definitely not going to give any clearance for immune suppression. So let us do some literature review. What are the causes of renal involvement in HIV? And try to rule in or rule out one by one. So causes of renal involvement, acute kidney injury, mostly drugs. Let it be tenofovir, which has already been stopped 6 days before patient coming to us, and still his creatinine is rising. Other drugs are Bactrim, patient was not on because of the good CD4 count. Other drugs are atazanavir, acyclovir, but patient did not receive any of these drugs. Any infection, any UTI which is causing AKI, any stones, anything like that, we couldn't find any of those things. Can this be HIV-associated nephropathy? Because whenever we see a patient with HIV with altered creatinine in the absence of identifiable causes, we tend to attribute it to HIV-associated nephropathy. But you need to remember here that it is predominantly seen in patients with high viral load and low, which is not the case in the present scenario. In the availability of the good ART, patients will not be having HIV-1 or HIV-associated nephropathy that commonly. I will show you some literature supporting that. In chronic kidney disease, again, the HIV-associated nephropathy is one of the reasons. Other reasons are immune complex kidney diseases. That is membranous, membranoproliferative, lupus-like proliferative glomerulonephritis, and IgA nephropathy. So these are all the causes which can cause secondary membranous nephropathy. Apart from that, hepatitis C. Now, as usual, in all this kind of presentation, we tend to hide some of the investigations. So we did that, or I did that in this case, which I'm going to reveal in a next slide. So simple thing, he was syphilis, positive for syphilis. VDRL was, titer was 1:8. Now question is whether syphilis is sitting here as innocent bystander, as a latent syphilis, or whether this is a cause for membranous nephropathy. So we need to establish a causal relationship that syphilis in HIV infected patients leads to membranous nephropathy. For that, we did more digging in the literature. Causes of membranous nephropathy, idiopathic, this is not the case. What are the secondary causes of membranous nephropathy? Apart from malignant tumors, medications, autoimmune diseases, infections. Look at this. Syphilis. Syphilis is one of the cause of secondary membranous nephropathy. Now let us prove it from the right side also. What are the renal manifestations of syphilis? So these are all the renal manifestations of syphilis, right? Again, we know that syphilis is a great imitator. It involves all the systems of the body. The similar way involves all structures of the kidney. Let it be glomeruli, tubules, vascular, and mass lesion. So membranous nephropathy can be a reason for syphilis damaging the kidney. So we have some data suggesting that syphilis can cause nephropathy. Now important question comes, is it reversible or not? Because here nephrologist is asking us to clear patient for immunosuppressant. We do not know whether this case requires only treatment for syphilis, or we need to give immunosuppression also. So we did more literature search, and what we found is there are various case reports and case series. Trust me, there are not more than 50-60 cases of this. That too much if I'm mentioning in terms of numbers. So here I have a young male who was HIV positive, virologically and immunologically well controlled. He had documented syphilis infection, probably clinically fitting into the secondary syphilis. He had some transaminitis also along with the membranous nephropathy and the rapid reversal of all kidney involvement and liver enzymes by single dose of benzathine penicillin. So this gives us a great feeling that only treatment of syphilis can take care of this membranous nephropathy. We do not require any immunosuppression. Similar case, syphilis associated with acute renal failure and hepatitis in a setting of HIV co-infection, 2 cases, 1 more case. Here, all those cases were presented in a stage of secondary syphilis, where our patient, we are thinking that he must be having a latent phase of syphilis. So here again, more literature search, they found membranous glomerulonephritis caused by syphilis in elderly male, who is well controlled for HIV perspective. He had neurosyphilis also, along with the membranous nephropathy, and again, complete reversal of the membranous nephropathy with penicillin. This is very important article published from India. They tried to look for the kidney disease in HIV infected patients, and what they found is HIVAN is not the most common presentation or most common cause of renal involvement. So always, whenever we are seeing HIV patients with altered renal function in the absence of identifiable causes, do not attribute it to HIVAN, because a good CD4 count and a good HIV viral load control excludes HIVAN. That's a very important point. So back to the case. So it's a Christmas cake by the end of the month that we got answers to most important 2 questions. Can syphilis lead to membranous nephropathy? Yes, we have a literature supporting that. Second question, can treatment of syphilis cause reversal of nephropathy? Very much yes. Patient was started on weekly benzathine penicillin and showed dramatic improvement on follow-up at 1 week, which was improvement in the creatinine and proteinuria. At this point of time, we with some guts, we started patient on the TEF, FTC and DTG because we didn't have much options. Patient was doing well. Last follow-up was 4 weeks after the treatment, and patient showed significant reduction in the proteinuria and the creatinine was normalized. This is the creatinine. This is like roughly 10 days into the treatment, and this is 1 month into the treatment. So patient is doing really well. So take-home message from this case, nephrotic syndrome in a patient with HIV may not be necessarily caused by the HIVAN, especially in the era of heart. And the syphilis is very important, and most important than that is completely reversible cause for the membranous nephropathy. I would like to quickly go to the next case. And next case, I would like to title as cherry on the cake. Any guesses? I wish this could be a in-person session. Most of the audience would have guessed it. That we got from this case, we got some extra information, and the cake was cooking since first week of December. We took a history of wife. So she was 60-year-old diabetic, hypertensive with dyslipidemic, although we did not consulted in person ever because she was not in a mobile condition to come to the clinic. They were staying in some different, quite a different village. She gave a history of recurrent strokes since 2014. She had developed 4 episodes till date and some personality changes. This is what the caretaker and the distant relatives could convey. We could not examine the patient. At that point of time was HIV negative. Still, she is HIV negative. Her TPH is positive, and his VDRL titer is more than her husband's VDRL titer. That is 1:128. So at this point of time, we asked her to get admitted and get the CSF done to rule out meningovascular syphilis, because we didn't have, apart from her chronic underlying condition, we wanted to rule out meningovascular syphilis or neurosyphilis in this case because of the presence of recurrent stroke. But they were not willing at that point of time. So we started treating that patient as latent syphilis with 3 weekly doses of benzathine penicillin. Luckily, when I wanted to take a follow-up for this presentation, I spoke to them and I came to know that that patient is admitted under a neurologist with the 5th episode of stroke. And with no time, I took opportunity to talk to the neurologist. I explained the relatives as well as the neurologist the need for the evaluation for neurosyphilis. Luckily, he got convinced as well as the relatives because the patient was already admitted in the hospital. The CSF was done, the 103, sugar was 60, simultaneous sugar of 120, total by 3, all lymphocytes, and CSF, VDRL, and TPH negative. CT angiography, which was done, was suggestive vasculitis. This is neurosyphilis, or this is just an ischemic stroke with latent syphilis. So, and the most important question, do we need to treat this patient as neurosyphilis? So again, only literature can help. So what is meningovascular syphilis? Neurosyphilis can present in the early, middle, as well as the late stage. In meningovascular syphilis, generally what happens is infectious arteritis, which leads to occlusion of the arteries, leading to the thrombosis, ischemia, and infarction. Generally, it presents as ischemic stroke in young people. So that is where we tend to test. Generally, it can present from the initial first months to first few years after infection. In the pre-antibiotic era, it used to present roughly on an average 7 years after the first infection. Patients can have many prodromal symptoms, which may be suggestive of concomitant meningitis. The CSF abnormalities are less severe compared to the meningitis. They will have some CSF lymphocytosis, 10 to 100 cells, protein of 100 to 200. As with all early symptomatic forms of neurosyphilis, CSF VDRL is usually, but not always reactive. This is very important point to be considered, that negative CSF VDRL will not rule out neurosyphilis. Angiography generally shows form of vasculitis in forms of focal dilatation or narrowing, and neuroimaging shows one or more areas of infarction. So this we all know that whenever we want to go for the syphilis diagnosis, we go for both the things, non-treponemal test as well as treponemal test. I will showing the algorithm in a second. So generally non-treponemal test, that's VDRL and RPR, will be negative in the early as well as the late syphilis. So we cannot solely rely on them for the screening for syphilis. Treponemal tests are the mainstay, and once reactive, they stay reactive for the life. So always go for the treponemal test. Second is non-treponemal test. While reactive CSF VDRL establishes the diagnosis for neurosyphilis, it does not, negative test does not rule out the diagnosis. That's very important because the sensitivity of the CSF VDRL is always 67 to 72%. And one more thing, we should never go for the CSF RPR because its sensitivity is even less than the VDRL. So whenever we want to suspect or diagnose or rule in, rule out neurosyphilis, always go for the CSF VDRL test. There is one more test, it is FTA-ABS, which is very sensitive but not very specific. And whenever we are suspecting neurosyphilis, a non-reactive CSF FTA rules out asymptomatic neurosyphilis. So this is a very important algorithm for HIV negative patient, as like in our present case. Always go for the syphilis specific antibodies, treponemal specific antibodies. If they are non-reactive, syphilis is ruled out. If they are reactive, whether patient has neurosyphilis or not, whether they have neurological symptoms or not. If they have any neurological symptoms, go for the LP. When we are going for the LP, first see CSF VDRL. If it is reactive, we are going to treat for neurosyphilis, which was not in our case. If it is non-reactive, go check the cell count. Again, less than 5 as in our case. Still, the protein is high. We need to treat as neurosyphilis. So our patient qualifies for the neurosyphilis, and we did treat our patient with the neurosyphilis. This patient was started on injection ceftriaxone because of non-availability of the penicillin. When we are talking, she is receiving 12th dose of treatment. Clinically, she is improving. So this became a cherry on the cake for us because we got get one buy one free. So take home message from this: Neurosyphilis requires a high index of suspicion and lower threshold for therapeutic lumbar puncture as well as treatment. And negative CSF VDRL does not exclude neurosyphilis. I would like to rest my case here and hand it over to Dr. Vinay, who will take us to the emergencies in HIV. Thank you.
Thank you, Dr. Swati, presenting two interesting cases one by one. So let's go to Dr. Vinay. Dr. Vinay, you can share your presentation. Ma'am, you need to stop your...
Yes.
Hoping my screen is visible. So pardon me, my voice has just gone for a toss, bad URI. I'll try to be as audible and as loud as possible to make it as a clear and crisp presentation. Thanks, Swati. Thanks for letting me go next. And thank you, team MCure, for organizing this event where we can discuss certain important aspects of HIV. So as has been told, I'll be talking about presentation of acute emergencies in HIV. So I'll try to go in a concise manner because the topic itself is too huge to encompass and put a few things in 20 to 25 minutes. So what I'll be giving or presenting to you will be a clinical case-based approach as to how you can identify emergencies and how we can attribute this to HIV and in what situations these two present with us, and then how to go along diagnosing and treating them. HIV has come a long way since being an innocuous simian immunodeficiency virus, which hardly did anything to humans, to the more aggressive current HIV, which through series of multiple mutation has turned out dreadful. And at the same time, we have seen evolution of antiretroviral therapy from a non-existent state to extremely useful, beneficial, and safe mode of drugs. And we have reached to a point where we know that as soon as the diagnosis of HIV is made, we need to start that person on antiretroviral therapy. One which reduces infectivity by a great deal and increases and improves the overall life and quality of the person infected and people surrounding him. So from this point, what is not changed is how HIV behaves if someone is not treated. So the natural cycle of HIV clearly shows it goes through a phase where there is initial high spike viremia, then it reaches a plateau which will be sustained for many years even if not treated. But at some point it decides to break loose, and maybe after anywhere from 1 to 15 years, it begins to increase again. At the same time, associated with a drop in CD4 count, the immunity takes a bad hit. Numerous opportunistic infections come into picture, and ultimately leading to death over a period of 2 to 3 years once this happens. So treatment, if we intervene at the right point of time, like I said, does two things. One, improves the quality of life, prolongs the survival period for the individual infected, and at the same time, it reduces infectivity by a great deal. But not everyone comes with a slate or a board hanging of HIV, and that's not a straightforward diagnosis. More often than not, if we do not suspect in certain cases, we may even miss the diagnosis. So my presentation harps on how do we go about and how do we identify these cases and in what scenario do they come to us. So by and large, the emergencies in HIV can be seen in the phase of acute syndrome, that is in the first 6 to 12 weeks, or in much advanced stage where the CD4 is dropping and is entered into the CDC3 or advanced stage of HIV. So how are the presentations? So what we usually see is an incidentally detected HIV where some illness or some surgical emergency, we do random testing and then it turns out to be HIV in the given individual. This is the most common presentation. When it comes to proper emergencies, most often the most common emergency presentation of HIV is in terms of the opportunistic infections. Then less likely it is due to acute HIV syndrome. IRIS is one of the important emergency mode of presentation of HIV. And of course, an emergency also arises when there is a needle stick injury. You need to protect our healthcare staff as well. That itself in an emergency, we need to understand how do we treat and how do we approach. So let me try and decipher each of these things one by one. So to begin with, like I said, acute HIV syndrome, not the most common mode of presentation in an emergency, but of course it is. Reason, again, as mentioned previously, it is a phase where the virus is aggressively multiplying. There is a high degree of viremia, and it is a phase where in the initial few weeks, maybe 2, 4, or 6 weeks, the antibody may not be obvious. So even if you suspect and do an antibody testing at this part of time, you may not even identify the HIV infection. So now there is advancement in terms of our fourth generation tests, which also use P24 antigen. And with extreme suspicion, they may be use of viral load also. So in simple terms, acute HIV syndrome is something which presents with a mononucleosis-like picture. That is, it presents like any other viral illness, maybe upper respiratory symptoms, maybe high-grade fever, rash, arthralgia. You may not even pinpoint and exactly say this is because of HIV. So it is masked by its presentation, overlaps with many other illnesses. And unless and until you clearly identify based on tests, this multi-system presentation of acute HIV syndrome with various varieties of rash also may completely be missed. So what I'm trying to emphasize is that you may miss if you do not suspect. So how do we suspect, and how do we, even if we suspect, how do we confirm? Clinical symptoms are not very pathognomonic of acute HIV syndrome. You'll have to completely depend on bank on the diagnostics. But diagnostics also have their drawback. You need to understand there is something called a window period where the patient may be infected, may have viremia, but the antibody might still not have shown up. So that is the window period. So is viremia doesn't start on day one itself. It is not identified immediately. So you should know the time when the identification is easy. Viral load or the virus multiplication is picked up earliest by day 11. The P24 antigen earliest shows up in the blood by day 14, whereas antibody shows up by day 21 at the earliest. So remember, I'm emphasizing on the fact that this is the earliest identification picture. It may be delayed by a week or more also. So why we should understand this is, if there is a strong suspicion of HIV, you do these fourth generation tests and turns out to be negative, but you still have a strong suspicion, please do follow up. You may repeat a test after 4 to 6 weeks, and then maybe the test turns positive. It has happened before. So keep a close watch on these set of patients. Always counsel them and then make sure they do come back for follow-up so that it is not missed. Because if we treat early, we make sure that the quality of life and the duration of life is much longer than it is. Since HIV just goes through a series of enzyme-based multiplication entry and then further multiplication and then exit. So the drugs are also based on these. So we have various sets of drugs. We usually use a backbone of nucleoside or nucleotide reverse transcriptase inhibitors, along with a second combination of protease inhibitor, or now most common preferred group is the INSTI, integrase strand transfer inhibitor. So even if you identify a person with acute HIV syndrome, the approach to treatment remains the same as anybody with HIV. You go with 2 NRTIs with an INSTI. That is usually what we prefer is dolutegravir, because there are combination regimens, once daily use, very safe, very efficacious, and they bring down the viremia to a great extent in a very rapid manner. So that is the preferred mode of treatment, even when there is someone who's been diagnosed with acute HIV syndrome. Also remember, you diagnose HIV, the job doesn't stop there. You need to also identify if there is any other associated infection which needs to be dealt with same degree of aggression and commitment. So look for possibilities of associated hepatitis B, hepatitis C, syphilis, which was shown in the previous case. Do a TPHA and a VDRL at the same time. Look for viral load and CD4 count. Yes, always ask for creatinine. And in a woman of reproductive age group, it's always wise to ask for a urine pregnancy test before you initiate antiretroviral therapy, because if there is someone who's already pregnant without being exposed to ART, there is always a risk of a congenital transfer, which we need to discuss with the family before we go ahead and start off with antiretroviral therapy. So not going into much details, what is now preferred, like I said, among the NRTI, we go with the tenofovir. Alafenamide is the most common conjugate that is used, because the risk of renal tubular damage and osteoporosis is significantly cut down. And dolutegravir is the most preferred INSTI and the most widely available also. It has stood the test of time, and then last couple of years or more, it has turned out to be a great help to the physicians, to ID physicians who treat HIV. So the response to this drug has been extremely good. But always keep in mind the risk of drug interactions. Please do cut down the dose in certain situations. If at all there is a patient on ATT and he's on rifampicin, you need to remember the dosing of dolutegravir is twice. This is very crucial, and ideal to avoid the use of dolutegravir with oxcarbazepine, phenobarbital, or phenytoin. So always take a history of other drug use before you initiate any ART, and particularly when it comes to dolutegravir. How do you monitor after you identify an acute HIV syndrome? Do a follow-up viral RNA levels or the viral load 4 to 6 weeks after you initiate the treatment. Make sure there is at least 1 log reduction by 6 weeks or so. By the end of 3 to 4 months, that is 12 to 16 weeks, if you do not see much response to antiretroviral therapy, maybe there is already an inherent resistance and the drug might be failing. In such situation, ideal to ask for a genotypic or a mutation analysis. If the patient is doing well, trust me, this happens in 99.9% of the cases. Viral load is well suppressed within a very short time. You can follow up these set of patients every 6 to 12 months, depending on the clinical progress. So this is how you approach and manage acute HIV syndrome. Like I said, it's not a very common presentation. What is a common presentation for a treating physician is emergencies related to HIV in terms of opportunistic infections. And if you segregate and put them into individual boxes, you usually see these emergencies are got to do with respiratory system by and large, followed by neurologic, and there are very few other non-respiratory, non-neurological emergencies that do happen. Among the respiratory pathologies which may present in an HIV individual as an opportunistic infection, it goes across spectrum of illnesses. So it may be bacterial, viral, fungal, or mycobacterial. So like I said in the beginning, nobody comes with a brand or label of HIV. If you have a person who has HIV, is or is not on antiretroviral therapy, it may make it easy for you to, okay, maybe this is the opportunistic infection I'm looking at. But what if an individual presents to you with any of these illnesses without having knowledge of HIV himself? That makes life tough. If by any chance you already know the patient has HIV or you identify HIV, what might guide you to the diagnosis of this emergency situation in respiratory illnesses may be the CD4 count. Across any CD4 count, TB is always a possibility. If an individual has a healthy CD4 count, say of more than 200, 250, bacterial pneumonia is one of the most common respiratory emergencies. An individual with less than 200, PCP comes into picture very strongly. Though less likely, cryptococcal pneumonia is one thing which you need to keep in mind. But when the CD4 is dropped to less than CD4, fungi like Aspergillus, Histoplasma, and viruses like CMV come into picture. Please do remember, CMV is bad news when it comes to HIV. An individual with extreme immunosuppression, not on any sort of antiretroviral therapy, if he has CMV, that is one of the most common poor prognostic factors. So need to identify and treat it early so that these individuals do well. So like I said, if you know about the patient's HIV status, it is easy based on CD4 count to think about it, though not very easy in a practical situation. If you do not know, if a patient is presented to you first, you're in the emergency, you're in critical care setting, so how do you go about? So I would, for the sake of convenience, divide it to respiratory emergencies which present in an acute manner and subacute manner. Something which presents as an acute febrile respiratory illness, maybe with type 1 respiratory failure, presents with a lobar picture, I would consider bacterial pneumonia as a possibility if it's an acute presentation. So if it is confirmed, you need to understand that most common organism responsible is still pneumococcus, even if it is immunocompetent or immunocompromised. And in individuals who have a background history of IV drug use, always suspect MRSA as a possibility. So if you do not know the underlying HIV status, when do you suspect HIV and start diagnosing these individuals? When there is more than one bacterial pneumonia in a given year, always suspect a possibility of underlying HIV. No harm testing, no harm asking for it. So once you start treating bacterial pneumonia, always make sure you start antiretroviral therapy at the earliest. Now in subacute presentation, you have a respiratory emergency which presents in a subacute manner. Patient has progressive dyspnea with or without fever, dry cough predominantly, sometimes associated or most often associated with oropharyngeal candidiasis, weight loss. And you see this pattern of reticular picture on radiology, this typical appearance on a CT chest. You already know the diagnosis is PCP or pneumocystis jirovecii pneumonia. So very important, because if at all you do not identify early, it's got a great degree of mortality. If the patient has PCP and ends up in ICU, the mortality can go up to 30%. There is a close to 10% risk of pneumothorax in these individuals, and hence the need to identify early. Sometimes empirical therapy also comes into picture based on radiology and clinical presentation. And also CD4 less than 200 always would add to the favor that it could be PCP with a typical radiological picture. Then again, a subacute presentation with productive cough, febrile illness, low bar, cavitary, or many other modes of presentation, pulmonary tuberculosis would always be around the corner. It should be at the back of your mind, and consider that in Indian scenario, never forget tuberculosis. It's always there. So you identify, the same rules apply. AFP smear in sputum, or you need a bronchoscopy sometimes to identify. You do a gene expert, and as soon as you suspect pulmonary TB, please initiate airborne precautions, because these set of individuals have high degree of mycobacterial replication and are highly infective. So if you look at it in a retrospect manner, maybe radiology and the mode of clinical picture comes to use. In individual who's presented in an acute manner, if he has a normal chest radiograph, it could be something like an influenza or maybe an early bacterial pneumonia. So think of it, and sometimes it may be PCP. You may consider empirical treatment. But a bad chest X-ray or a bad CT may give you a clue. It could be bacterial, PCP, or TB. Somebody's presentation more than 1 week, bacterial pneumonia becomes lesser and lesser as a possibility. TB and PCP remain in the picture. With a very low CD4 count, CMV is always around the corner. So you can take multiple clues, the way or the acuteness with which the patient presented, the radiological picture, the type of clinical picture, and once you diagnose, the CD4 count might guide you as to what is this respiratory emergency indicating. So apart from respiratory emergencies, some things which we commonly see in HIV setting is neurological emergency. Again, you can make use of the same set of principles. If you do not know the underlying HIV status, it is an initial diagnosis, or you still haven't suspected, look at the mode of presentation, acute, subacute, or chronic. Or if you already know, or then you diagnose HIV, make use of the CD4 count to try and see what it could be. Something, a neurological emergency which presents over days. And at any CD4 count, it could be herpes encephalitis or bacterial meningitis, or something with a CD4 count of less than 200, maybe toxoplasma. You need to closely differentiate it from TB, or something with a CD4 count of less than 50, CMV and cryptococcal meningitis are always a possibility in presentation as an acute manner. Something presenting subacute over weeks at any CD4 count, tubercular meningitis is always there as a possibility, and you need to think of primary CNS lymphoma if it is less than 100 CD4. Presenting over months, TBM is still a possibility, but you should not forget progressive multifocal leukoencephalopathy involving the white matter, and usually lesser CD4 in somebody who's not on ART or is taking the older generation ARTs with no good CNS blood-brain barrier penetration. PML should always be considered as a possibility. You can take certain other clues. Neurological emergencies usually are not that straightforward, but they may be subtle clues which you can make use of. Like I told you, you may not know the patient is or has HIV, you still haven't suspected. But once you know, or once you think of it, immediately look at the clinical picture. Less likely to unlikely presenting as fever are PML and primary CNS lymphoma. Headache as a predominant presentation could be pointing towards cryptococcal meningitis. Almost all of these things can present as altered sensorium, barring PML and primary CNS lymphoma in the early stages. So the clinical clues are very subtle, but if you suspect and you have a CD4 picture, you may pinpoint and say, okay, this could be the diagnosis. So what will come in to help then? You do a CSF analysis, you go in a protocolized manner, you do a CSF analysis. If you have a neutrophilic pleocytosis, it more is in favor of bacterial meningitis or maybe CMV in the early stage. That's also a possibility. A lymphocyte predominant presentation, of course, would be a tubercular meningitis, cryptococcal, even herpes. You use other clues to diagnose also. Whereas CNS or CSF analysis may be by and large normal in those with PML and primary CNS lymphoma. So you know the specific set of tests that needs to be done. Follow up, do the tests on CSF, and there you might have a clue. Radiology sometimes might also give you a clue along with CSF analysis as to what could be the neurological emergency due to. Confusion is usually between toxoplasma and TBM, but presence of a multifocal presentation, not so much of altered sensorium or fever, might clinch the diagnosis towards toxoplasma, and other illnesses or other clues may be towards tubercular meningitis. Predominant white matter presentation in an individual with extremely low CD4 count, PML should always be thought of as a possibility. Always test for cryptococcus when it comes to HIV with meningitis. So can you go in a stepwise manner and try and identify what could be the illness due to? Yes, so if an individual comes to you with a clinical picture consistent with meningitis, always try and look for underlying possibility of HIV. If there are clues abundant, go for neuroimaging, MRI or CT. If you don't see a mass lesion, your clinical suspicion is meningitis, go for lumbar puncture and then follow up with the tests. So tests are plenty, but depending on the clinical scenario, Of course, gram stain culture is always on the card, AFP smear, gene expert, and cryptococcal antigen always a mandatory necessity when you do a lumbar puncture and a CSF analysis. You do find certain lesions, look at any signs of herniation. If already herniating, you'll definitely need help of neurosurgical team and ask for a brain biopsy at the same time. These kind of situations or presentation nowadays are rare. But with no sign of herniation and presence of mass lesion, look at the type of presentation. Is it a solitary lesion or multiple lesions? Solitary lesion could be anything. It could be tuberculoma, it could be toxoplasma, it could be even cryptococcus also. If lumbar puncture gives you a clue, good enough. In rare situations, brain biopsy comes into picture because certain malignancies, including primary CNS lymphoma, might also present that way. Multiple lesions, do a toxoplasma serology, ask for toxoplasma, IgG or PCR in the CSF. If you find a conclusive proof, good enough, you start treating for it. No proof, but other diagnosis also uncertain, you may give a trial of therapy for toxoplasma, and if it doesn't help, a second CSF or a brain biopsy comes into picture. So you can go in an organized and a stepwise manner so that you do not miss the diagnosis in an individual presenting with HIV and neurological emergencies. So a lot of clues, including the type of presentation, duration, CD4, all of it can give you clues, and investigations can take you across to identify what it could be. So there are many other emergencies which can also present. I'll not be going into details of those, including zoster ophthalmicus, toxoplasma retinitis, diarrhea presenting with shock. So there are many other infections which can follow through. And if HIV is identified, you know, based on CD4 count, what could be the presentation. Once you have an opportunistic infection as an initial presentation of HIV, you need to start them on antiretroviral therapy. Same rules apply, but the question is, when do you start? Once you're diagnosed for many infections, almost all of them, you start at the earliest, barring few where you need to take certain precautions. If pneumocystis is your infection or your diagnosis, start ART within 2 weeks, ensure good clinical stability. If it is tuberculosis, the general rule, even though there are certain exceptions and newer studies pointing to our early use, if the CD4 is less than 50, start by 2 weeks, not within that, by 2 weeks of your diagnosis and ATT initiation. If CD4 is more than 50, you can take time, maybe 4 to 8 weeks by the time which you can start ART. Cryptococcal meningitis, early initiation, most studies say, or general following is that it can lead to bad iris later on, particularly if it is an acellular CSF with cryptococcus, and it could lead to bad iris, which may increase the mortality. So waiting for 4 to 8 weeks, unless until there is no pressing indication, ART can be delayed by that period. Then other acute emergency in an HIV setting is, of course, of iris. So most common TB, primary CNS lymphoma, and cryptococcus are the ones present with iris. So simple rule, iris is not a straightforward diagnosis, but rule of thumb, an individual who started on particular therapy, did well initially, control followed by worsening and presentation of similar symptoms, viral load well controlled, CD4 improving, you start thinking of iris as a possibility. Iris by itself is a huge topic. So this is, I'm just giving you a general overview as to when do you suspect and when do you start thinking of iris. Because if you start increasing the dose of current drug, it may do more harm. You may have to think about giving anti-inflammatory steroids and other things when iris comes into picture. Antiretroviral therapy in itself can lead to certain problems which the patient might present to you in an emergency setting. If somebody comes to you with SJS10, so there are certain drugs which are prone to do that, including nevirapine, which was notorious, efavirenz sometimes, and even darunavir. So you need to keep them in mind. If there is a patient of yours who's been on these therapies, there are some who still are on nevirapine and efavirenz, you need to make sure that these drugs are off the list. Someone who's had changes in ART presents to you within few days to weeks of change in ART with rash, fever, malaise, significant pain, abdomen, diarrhea, and arthralgia, always suspect and go back and see if the list has abacavir. So somebody not tested for HLA-B5701 lacks it, and then it's been started on abacavir, can result in abacavir hypersensitivity and acute worsening. So then abacavir has to be taken off. Drugs which can present with lactic acidosis and pancreatitis, zidovudine, and those who are on protease inhibitors can also present in an emergency with acute coronary event. So know the list, know the drug, know their side effects, then you can identify what could be the reason why they landed up in emergency. Other emergency, of course, I mean, you might not think of it as an emergency, but those who've gone through it, it's such an anxious state. Needle stick injury. Healthcare staff usually, the risk is highest if the underlying patient status is of HIV positivity, and it's a deep or a percutaneous injury, freshly used sharps with visible blood on them, or a needle with blood still, then the risk is highest. So also when the patient status is unknown in terms of ART initiation, patient is lost or dead, and patient's viral load is not controlled, patient not on treatment, or patient is having more than one infection like hepatitis B and C, the risk of the healthcare staff getting infected is highest. So in such situations, counsel them, start with ART at the earliest. If possible, counsel the underlying patient and try to get the ART status, their adherence, look for HIV quantitative PCR. A well-controlled HIV in the patient might be some good news for the healthcare staff, for those who undergone needle stick injury, but you need to have a close watch, do a baseline HIV, and then start off with the ART regimen. So now the favored regimen is still based on tenofovir and emtricitabine along with dolutegravir. But whatever else is available in your setting, please start it off at the earliest. It may be raltegravir, dolutegravir, or even efavirenz. Try to ensure compliance, give them PEP for a month, and then do follow-up HIV testing at week 6 and week 16. If both these tests are negative, then you can safely say that they have escaped HIV infection even after a needle stick injury. So this is how HIV can present in an emergency setting. It can present with acute HIV syndrome. There may be opportunistic infections coming your way. It may be iris, or it may be due to needle stick injury. So always have a clinical acumen to suspect. And if there is a suspicion, please have a low threshold to test, because if you test early and treat early, you can improve the quality of life and prevent it from spreading on to others. Thank you.
So thank you very much, Dr. Vinay and Dr. Swati. So we have completed our two lectures, and now this is open for question and answer. So we have few questions also which we have received. So Dr. Vinay, can you stop your presentation?
One moment.
Okay. So it was a very nice session. We have a very interesting two case presentations of syphilis, and followed by the acute emergencies in HIV. And I really like to how the Dr. Vinay has categorized respiratory, neurologic, and other regimes. So that's really nice. So there's a question by Dr. Rucha Karat to Dr. Swati. The percentage of CSF VDRL negativity in neurosyphilis. So what is the percentage of negativity, VDRL negativity in CSF?
So whatever available data and studies we have, it says that the sensitivity of CSF VDRL is roughly 65 to 70%.
Oh.
Right. So we are going to miss 30% of the cases if we are doing or relying upon only CSF VDRL as a screening test for the syphilis.
Okay. Got it. So another question which was at the very beginning when you were presenting the session, Q, what are the so the question was that what is the incidence of abacavir sensitivity in India?
Yeah, so that's actually a very good question. See, it's a caveat. Not every patient with HLA-B 5701 positivity are going to get abacavir sensitivity, abacavir hypersensitivity.
Yeah.
So exact incidence we know, like worldwide, it is quite less. I would say below 10%. Okay, Indian data I'm not aware of, but definitely less than that.
Okay, and ma'am, in your patient first case that you have showed us, the patient received finally TAF and FTC and DTG. So what is your views in current situation about two drug regimes of the dolutegravir and lamivudine, particularly in that patient?
Yeah, so I did think about the same regimen at that point of time, so that I can, get away with the nephrotoxicity. There were two issues in this case particularly. One was my personal issue. I'm not very comfortable with dual drug regimen. Whenever a patient is having one or the other OI going on, although patient is well controlled at that point of time, but still I'm not comfortable unless patient is stable, documented virologically suppressed for more than 6 months, and going to be in prolonged follow-up kind of a thing. Second query was, I didn't know that like what will be the rise in creatinine regarding the lamivudine dose adjustment. But that was not a major issue for me. But I was not comfortable at that point of time because dual drug regimen, we have to ensure that patient is virologically well controlled, and we have to rule out resistant mutations to both the drugs whenever we are going to rely on dual drug regimens.
Okay, thank you. Thank you very much, ma'am. There was a very nice comment by Dr. Ananda Rao. Your case was a wonderful Sherlock Holmes kind of a case investigation.
Thanks a lot.
Is saying. So another question, ma'am, can syphilis transmission can be prevented by barrier method of contraception?
Yeah, so see, we need to understand that syphilis is transmissible in early stages, mainly during the primary and secondary stage. Primary stage mainly by contact with the genital ulcers, because they will have active spirochetes in that can definitely be prevented by using barrier methods of contraceptions. But in secondary syphilis, patients can have oral lesions, they can have lesions in the palms and soles. So only the barrier method might not be effective in those cases. There are rare incidences where we can get by open cuts and things on our hands, we can get infection by that. So only barrier method will not be effective in such cases.
So maybe for both the faculty, there's a question: if there's a recently detected HIV, should we include syphilis as a part of workup?
100%, without any doubt.
Okay. So that's very important. So, ma'am, thank you very much. This was few questions which I could see, and maybe few questions to Dr. Vinay also. There's a question from an anonymous. I could not know who's the doctor, but is there any increased chances of iris in patients receiving dolutegravir?
I don't think it is drug related. It's not drug specific. It is patient specific. So the underlying factors remain the same as before. If somebody before initiation of ART had a high viral load, had a very low CD4 count, you can't quantify the number, but let's say less than 200, or presented with opportunistic infection to begin with, and has many other associated comorbidities or multiple other infections along with HIV, in these individuals, the risk of iris remains. Theoretically speaking, because dolutegravir causes a rapid suppression of the viral load, it was theorized that probably it leads to increased incidence of iris. But I don't think there are any studies which conclusively proved that dolutegravir increased the incidence. It is still dependent on patient factor, where if you have a bad presentation initially, the risk of iris also increases. And further, iris may be of various grades. You may see many subtle presentations which are iris, but you still may miss where the patient had a high viral load and CD4 count, but we continue using ART, maybe some symptomatic treatment, they continue to do well. Only those who had very severe presentation with a bad immune system with a very low CD4 count end up having bad iris later, which again can be managed very much easily. And it is not, reiterating, it's not drug specific, it is patient specific.
Sir, do you do mention that CMV is one of the very bad prognostic infection. So how common is this CMV and how one should do the workup for CMV?
I think the incidence is quite difficult because the treating doctors are heterogeneous. And if you look at the data of CMV infection in HIV, it is not very easy to find because not everyone suspects CMV as a possibility. So the incidence still remains low, but we don't know what is the exact number. But when should you suspect CMV? Like I showed in my slides, if you have a respiratory illness with a CD4 of less than 50, or even if you have a neurological presentation with CD4 less than 50 or 100, you don't have an alternate diagnosis and the patient continues to worsen despite doing all necessary measures, think of CMV as a possibility. You can always do a CMV viral load from the serum, but please do remember CMV can reactivate with any other stresses. So if you see a high viremia, do not always attribute it to CMV disease. It may be mere reactivation. But if you have a consistent illness, let's say, for example, there is meningitis, which is neutrophilic, or there is pneumonia, which is kind of not densely lobar, but there is no alternate diagnosis. Or if you do a lung biopsy, someone good pulmonologist or intensivist courageous enough to do it, and you see inclusion bodies, then CMV comes into picture. But like I said, more often than not, it's like lack of alternate diagnosis, very low CD4 count, maybe a pneumonia-like picture, and then CMV viral load high, we suspect and start treating. So why I would say it is somewhat of a bad prognosis, for the reason that patient already is a poor prototype with a very low CD4 count, an advanced stage of HIV, and the time of onset of action of the specific drugs for CMV is quite delayed. And CMV being itself an aggressive disease, so may add on to poor prognosis of these patients. Quite honestly, in the last 8 years or 9 years, I think very few, 3 patients that I've lost, all of them had CMV disease in the lung. So barring that, if CMV is not in picture, and nowadays with good antiretrovirals, these patients continue to do well, even with a very bad presentation at the initial therapy, initial presentation.
So as we were discussing this, there's a question from Dr. Ananda Rao as well for related to CMV. So he's asking, can we have a CMV prophylaxis for a patients with CD4 count less than 50?
There's no role at all. So CMV always is somewhat of a controversial topic, even when it comes to transplant setting. So role of prophylaxis is quite controversial. So when you don't have a conclusive proof, guidelines, evidence to suggest that prophylaxis really helps, also the biggest drawback is the drugs used for CMV by themselves are marotoxic. So if there is a minute chance also that this is not CMV, you're exposing them to ganciclovir or valganciclovir with a high tendency for cytopenias, you're not justified in making life far worse for the patient. So for that reason, I think prophylaxis might never help in these set of situations.
So one more question.
Also, one more thing is, it's not that common. Like I said, for something which is not very common to add as a prophylaxis, I don't think you're justified in doing so.
So another question, what are the genotype analysis and mutation analysis in the treatment of failure?
Again, if you look at Western guidelines, they always say that you start off with genomic analysis. You look for NNRTIs, NRTIs, PIs to begin with, and then simultaneously start treatment. We don't do that. We don't do that for the reason of cost analysis. The cost benefit is not proven much. What we do here is, if we see a patient who's failing on a given regimen, despite being adherent to the given regimen, then we ask for genomic analysis. Most often, those patients who fail are the ones who are on older generation of ARTs. They may be with zidovudine, nevirapine or so. So in them, we do ask, and we see a lot of cross resistance. We see NRTI and NRTI mutations. In these individuals, if cost is not a constraint, I do ask for an INSTI also to begin with. But more often than not, we know the resistance rates for INSTI is quite negligible. So we ask for only NRTI, NNRTI, and PI. And depending on the resistance pattern, dolutegravir always comes into picture. What do we choose from these set of drugs depends on the individual and what is the result of genomic analysis.
So as you touch upon this dolutegravir, and you do mention that now it's a backbone and all these things. So there's a question related to that also, how to manage the dolutegravir induced hepatitis in asymptomatic patient when they have a high SGPT and SGOT levels.
One thing is, I think it's not that common. Of course, yes, it is there. If you follow, dolutegravir presenting as symptomatic hepatitis is extremely rare to unlikely. Dolutegravir having picked up on LFT analysis for some reason is the most common presentation. In that too, the number of patients who come with a significant alteration in liver function is extremely less. So you always look for, is there any symptomatic association between LFT worsening and the use of dolutegravir? If patient has a marginal increase in liver enzymes, I would just keep a close follow-up. I'll follow up the liver function test quite frequently. And if it is not worsening, if the patient is not symptomatic, I would not change the dose whatsoever at all. Only in very rare subset of patients where the hepatotoxicity is progressive, liver enzymes are elevated, or patient also has attributable symptoms, then I would consider going back to something like an efavirenz. Again, that is also a bit hepatotoxic, but you need to keep a close watch. But what gives us comfort is hepatotoxicity and symptomatic hepatotoxicity related to dolutegravir is quite less. I think we can still manage them with good follow-up.
Okay, thank you very much. I think we have covered a bit. There was a good compliment also, ma'am. You have shown a very nice flow chart about the treatment of syphilis and how it has to be divided. That was really good, and maybe the high level of suspicion that Dr. Vinay has added in acute HIV syndrome, that's and the window period and the test which is coming at what day, that was also nice. A lot of people appreciated that also. I think we have covered almost all the questions. I don't find any questions are left, but still there's just now we received a question, and would like to ask both the faculty, if resistance is proved for any triple drug regimes, so what would be your next step? That's what the doctor is asking. I don't know who. I just check who's the doctor. That is the question. And if the resistance proved for any triple drug regimes, what would be your next step for the management? Maybe the both of the faculty. We will have the both of opinion from both the faculty. Dr. Nagababu, he asked this question.
You can answer this, Swati, then I'll. If there's anything.
Yeah, so it's very important to differentiate between the drug resistance and drug non-adherence, because the first line ART, what we are using right now, which is dolutegravir-based therapy, it has a very high barrier to resistance. Second thing, even if on the genotypic study, we are finding resistance to the NRTIs, we have Nadia studies quoting that we can re-challenge with the same NRTI and the end result will not be different. So always, whenever before changing the ART, I think we should consider these two factors. One is check for the non-adherence, because that is way more common than the drug resistance, based on what first line ART we are using right now. And the second Nadia study says that the genotypic resistance will not be phenotypically expressed and will not be clinically significant every time. So these two things are very important to be considered in any patient before changing the ART.
Okay, and maybe Dr. Vinay, do you agree, or you have?
It's the same set of practice we do follow also. Now, if I have to rephrase your question, Dr. Nagbabu, I mean, you can't brand it as a triple regimen resistance. See, you need to look for individual drugs where the resistance is shown up to. Like I said, when we ask for a genomic analysis, we look at the class of drugs, NRTI, NNRTI, protease inhibitor. Very rarely we ask for INSTI also. So if you find resistance, you have certain set pattern of resistance in these, you try and see what is the resistance due to and what drugs we can make use of. Let's say, for example, resistance to emtricitabine, we still would continue. So what emtricitabine does is it reduces the viral fitness, but at the same time, it retains the activity of itself and other drugs. So we don't stop it. So this is not similar to what we do on blood culture studies for bacteria. This is entirely different. So you continue certain set of drugs. Now, the toughest situation is when almost all the drugs, right? So be it tenofovir, be it zerovodine, be it abacavir, be it efavirenz or others have shown resistance. What do you do? So that is the toughest situation. So in these, though it happens rarely, like what Dr. Swati said, re-challenge is one of the options. You recheck. Most often it works. But in rare situations when it does not work, now practice in certain institutes is to go for a dual regimen where you can have a combination of protease inhibitor with the INSTI like dolutegravir. You usually use darunavir with dolutegravir. That has proven success also, but it should not be a norm. It should be an exception. Or you go with lamivudine and dolutegravir combination also. Again, that also has certain success and benefit. But the chances, fortunately, of this extensive resistance is quite less. And you can always find certain drugs in the NRTI or NNRTI basket to make use of along with INSTI. So look for the drugs which are resistant, see how important they are, can you still retain and re-challenge them, and then make sure INSTI is one of the drugs with which these are added. INSTI at this point and also protease inhibitors have very high barrier for resistance. They do not easily fail. So you always have the option to use these drugs and still make the patient good. And we've also gone to an extent where even if there is multiple drug resistance, using of protease inhibitor, NRTI, along with dolutegravir has also had benefit. That is use of more than 3 drugs sometimes. Rarely is required. I've had such patients also, but they have done extremely well if at all we use the right combination.
So thank you very much. So last more than an hour, we were discussing very exciting topics. One was the case presentation and followed by the discussion about the acute emergencies. I think this is the time to stop at this point and maybe we will join one more day with another set of discussion. So I thanks to Dr. Swati for presenting 2 nice cases. At the same time, I thank Dr. Vinay for presenting acute emergencies in HIVs and very nicely differentiated into 3 segments, and that was very easy to understand. And we have more than 100 delegates witnessing this webinar across the country on the Saturday evening. So thank you very much, and we'll stop here, and when we'll join again another day with 2 more interesting case studies and the presentation. Thank you very much.
Thank you.
Thank you.
Thank you.
Good night.
Good night.